Så er vi faktisk kommet til vores første oplægsholder, Eric Dryver, som jo simpelthen er en af mine yndlingsakutmediciner, hvis man kan tillade sig at have sådan en. Men Eric Dryver, jeg ved, altså de fleste må jo kende Eric Dryver. Han er overlæge på akutklinikken i Skånes Universitetshospital i Lund, men derudover så er han jo skaberen af Emergency Medicine Core Competencies-kurserne, som efterhånden er obligatoriske i hele landet, tror jeg. Og dem, hvis I ikke har været på dem, så skal I se frem til dem. Det er simpelthen her, man bliver introduceret til den akutmedicinske tankegang. Og det er netop det, vi skal høre om i dag, hvor Eric Dryver, som desuden også har været chair for DASEM Education Committee og stået for det reviderede European Core Curriculum i akutmedicin, som jo altså kommer til at danne basis nok for vores næste reviderede målbeskrivelse. Det at han skal i dag præsentere os for den diagnostiske tankegang i akutafdelingen, probabilistisk tankegang og sådan. Jeg glæder mig meget i hvert fald. Og Eric, har vi dig med?
Yeah, can you hear me?
I hear you very well, thank you.
Good. I'll share my screen here. How does that look?
That looks perfect. Thank you.
And is the sound okay as well?
Yeah, I hear you loud and clear.
Perfect. Okay, well, I'd like to start off by thanking DASEM, and in particular, Emil Iversen and Peter Tagmose Thompson for giving me the opportunity to talk about diagnostic reasoning and decision-making. I think these are essential aspects of emergency medicine. I'm convinced that the more we collectively reflect upon and discuss these topics, the better we can be as emergency physicians. So this is a long session, and what Emil, Peter, and I decided to do was that I would talk about diagnostic reasoning for 40 minutes, and then after that, we will have a 20-minute question and answer period, which will also double as a break. So if people want to just take a leg stretch, that's a good time for that. And then we gather again at 10:15, talk about decision-making for 15 minutes, and then another question answer period. So in 1999, the Institute of Medicine published 2 Errors Human, and the authors report that between 50,000 and 100,000 Americans die each year because of medical errors, more than those who are killed by motor vehicle accidents or who die because of breast cancer. And then in 2015, the Institute of Medicine published Improving Diagnosis in Healthcare. And what they emphasize is that we need to get the diagnosis right, and that diagnostic errors impact on healthcare. They argue that this diagnostic errors represent a blind spot in the delivery of quality healthcare and continue to harm an unacceptable number of patients. And there have been, over the past 15, 20 years, quite a lot of articles have been published on diagnostic errors, the next frontier, and improving diagnosis in healthcare, the next imperative for patient safety, reducing diagnostic errors, why now? So the question is, why now? And I think it has to do with costs. Modern medicine is really fantastic. Patients come in, for example, with a STEMI and they look like crap, and they go up to the cath lab and the blood vessels open, and then within a couple of days, they're back home. And that is just amazing. And even though we in emergency medicine are on the periphery of this kind of process, I think we can derive some satisfaction from having contributed. But the patient can only benefit from all that modern medicine has to offer if we get the diagnosis right, or if the diagnostic process is not unnecessarily delayed. And patients also suffer from unnecessary treatments and tests. And then on the other side of things, modern medicine is expensive. And so ordering unnecessary tests and treatments consumes resources that could be spent in better ways. So how do we establish a diagnosis? How do we know whether a patient has pneumonia? And if we believe that there is some sort of objective reality out there, how do we figure out if something is true or false? Sean Spicer, who was Trump's press secretary, claimed that the crowd attending Trump's inauguration was the largest audience to ever witness an inauguration, period. And yet, when you look at these pictures of the mall in Washington, D.C., the pictures suggest that more people attended the inauguration of Obama in 2009, if you can see the picture on the left, compared to the inauguration of Trump in 2017 on the right. So how do we know what's true? And the best answer I've read goes as follows. First, we take into consideration the plausibility of the claim based on what we know about the world. So how likely is it that tons of people attended Trump's inauguration? And I would say, well, it's quite plausible. Millions of Americans love Trump. Okay, second, we take into consideration the track record of the source of the claim. Sean Spicer had by then a track record of repeating and defending baseless or false claims made by Trump. For example, that Obama had wiretapped Trump Towers. And then third, we look for independent verification. So we look for other photographs taken by other people from different angles to get a sense of how many people actually were there. So this is a Bayesian approach to truth. Here's a representation of Thomas Bayes, and this is Bayes' theorem. So we start off with pretest probability. How plausible is this claim to start off with from what we know about the world? And then we apply a test, and we get a test result, and we know something about the test characteristics, and this generates a post-test probability. And then this post-test probability can be the pretest probability for another test, which we then use to derive yet another post-test probability. So for example, if we want to know the probability of a DVT, we might use a D-dimer first, and then we do ultrasound. And obviously these two tests need to be independent from each other for this to apply. So independent tests. So Bayes' theorem again, so what's the probability of A, a PE, if B, the D-dimer is negative? Well, first of all, it's like, what's the probability of P to start off with? And then after that, you need to take into consideration how good D-dimer is at ruling out PE. Siddhartha Mukherjee wrote a book entitled The Laws of Medicine, and he argues that Bayes' theorem is one of the fundamental laws of medicine. And in retrospect, I'm surprised that it wasn't sort of banged into my head during medical school how important Bayes' theorem was in medicine. Bayes' theorem is also important in research. So here's an article from Nuzo, published in Nature 2014. The idea behind this paper was that we should not think about p-values in isolation. Even if a p-value is 0.01, if the pretest probability that the finding is true is only 5%, we get a post-test probability of only 30%. So we should think about p-values more as likelihood ratios, which I'm going to get to in a couple slides. This is Nate Silver, and he published a book entitled The Signal and the Noise, where he applies Bayes' theorem to all kinds of different phenomena in the world. And he applies it in particular to the Twin Towers crash. So this is what he does. He assumes that the probability that someone would deliberately crash a plane into a skyscraper is 0.005%. And he also assumes that the probability of crashing a plane into a skyscraper unintentionally or by accident is 0.008%. And that's based on some historical data of planes crashing into skyscrapers. And finally, he assumes that if you're flying a plane and you deliberately want to crash into a skyscraper, then you'll succeed. So based on these assumptions, after the first plane crashes into one of the Twin Towers, the probability this is a terrorist attack is 38%. It's still more likely that this was an accident. But then after the second plane crashes in, then the probability goes up to 99.99%. So it's still not 100%, but it's a very, very high percentage based on Bayes' theorem. So Bayes' theorem is not just relevant for medicine research, it's core to how we interpret the world around us. So here we have a 31-year-old woman, 31-year-old man with dyspnea who suddenly develops dyspnea while walking downtown. And he has IgA nephritis, and he's on an ACE inhibitor, and he's otherwise healthy. So here's the question: how likely do you think PE is based on available information here? I can't actually see the question and answer or the chat, but you can vote. And then he comes into the ED, and you take an EKG. And what this EKG shows here is a tachycardia. So on the left, the paper speed is 50 millimeters per second. So you can see that he has wide QRS complexes and a right bundle branch block. On the right-hand side of the screen, you can see a paper speed of 12.5 millimeters per second. And you can derive that he has a tachycardia of 140. So what do you think the revised probability of PE is now? Would you say low, medium, high, or very high? And then you do an ultrasound. And what you can see here, this is a 4-chamber view. On the top right side of the screen, that says left ventricle. And on the top left side of the screen, that says right ventricle, and the septum is bulging the wrong way. It's sort of like bulging into the left side, suggesting high pressures on the right side of the heart. So now the question is, in your head, what do you think the revised probability of PE is now? And what we've been doing there is basically Bayes' theorem, using different tests and revising our probability as we go along. And these are his vital signs. He had a respiratory rate of 40, saturation of 70, heart rate of 140. That's his blood pressure of 135 over 103, and he's alert and he doesn't have any fever. So one question that I would ask all of you is, how many of you would give him immediate thrombolysis? And this is getting a little bit ahead of the game, because this is not just about probability. This is about treatment and decision-making and the risks of being wrong. And we'll talk a little bit about that after the break. Here's Jerome Cassirer, and he wrote, "Absolute certainty in diagnosis is unattainable, no matter how much information we acquire." And I find this statement actually quite spooky. What do you mean we can't be 100% sure that you have lung cancer or PE? And it sort of is reminiscent of the weird world of quantum mechanics. Here's a picture of Werner Heisenberg, who is known for the uncertainty principle in quantum mechanics. And according to the uncertainty principle, it's not possible to fully ascertain the exact position and the exact momentum of a particle at the same time. So at a fundamental level, there's a degree of uncertainty or indeterminacy or randomness at the core of nature. And Albert Einstein did not like that. He famously said, God does not play dice with the universe. But certainly within the realm of emergency medicine, and we're quite familiar with the fact that there's a lot of uncertainty going on, that we have a lot of information that we're lacking. And Simon Carley has stated that we as emergency physicians are not really diagnosticians. We're more probabilisticians. So what information do we need to determine the probability of different diagnoses? So if you use Bayes' theorem as a framework, we need information to derive the pretest probability for a condition, and then we need information that will tweak this probability and move it up or move it down. So to derive the pretest probability of something, we need to know the prevalence of a condition in our patient population. And this will determine where we work. If I meet someone who smoked all of his life or her life and who comes in coughing blood, I think lung cancer. And if I'm working in Pakistan, I meet a young person who comes in coughing blood, I think tuberculosis. So we need to know the pretest probability where we work. And then we need to know how risk factors affect this pretest probability. And COVID has been a very interesting example of the value of Bayes' theorem. So there used to be a time when we asked patients whether they had traveled somewhere to Italy, for example. And we used this to determine what we thought the probability or the pretest probability of COVID was. And then after a while, when COVID went completely pandemic, it just didn't make any sense, or it wasn't meaningful anymore to ask about travel history. So we get our pretest probability from things like prevalence. And then what we need is we need to know how information we acquire from the history, the physical examination, the tests, tweaks this probability. And so there are all these different studies out there that look at the value, for example, of history. So if you look at this slide here, if the patient has pain radiation to both arms, that increases your likelihood ratio that the patient has an acute coronary syndrome. And here what you have is a likelihood ratio of 2.6. So what this means is that the odds of having an acute coronary syndrome have increased by a factor of 2.6 when you've acquired this information. So likelihood ratios are nicely suitable to Bayes' theorem. The odds of acute coronary syndrome when you have pain radiating to both arms is the odds that you had previously, your pretest odds multiplied by that likelihood ratio of 2.6. So there are studies out there that help us evaluate the value, the diagnostic value of information that we acquire. So here's one neat study where they took a bunch of surgeons and medical students and they recorded bowel sounds of patients who might or might not have bowel obstruction. And the physician had to listen to them and to decide whether they thought the patient had bowel obstruction or not. And you can see that if you think the patient has bowel obstruction based on how you listen, based on the bowel sounds, the likelihood ratio of for bowel obstruction is 1.9. So your odds have doubled about. And if you don't think so, well, they've decreased a little bit. Now you have to put that in contrast to ultrasound. So here you're doing point of care ultrasound and you find dilated lutes of bowel with altered peristalsis and other findings. And here your positive likelihood ratio is 27 as opposed to 2, and the negative likelihood ratio is 0.08. So ultrasound much, much better than the stethoscope when it comes to bowel obstruction. But then in other circumstances, it's the physical examination which has all the juice. So for example, if someone comes in with an isolated acute vestibular syndrome and you perform this examination called HINTS, where you combine head impulse test and test of skew, and you look at whether the nystagmus changes direction based on gaze. Well, if you're doing this correctly, you're more sensitive than an acute MRI. And that's fantastic. So I think it has to do with, we need to be good at knowing what the evidence is for these different tests that we can do at the bedside. And sometimes, surprisingly enough, very little information is required to be able to make a diagnosis. So here's the first poll here. This is a 26-year-old who comes in after a motorcycle accident. And what you pick up rather rapidly on your physical examination is that the patient has ptosis and meiosis on the left and a left-sided hemiparesis. So you can see the different choices. Where do you think the lesion is? And Emil, I'll need your guidance for when I should move on to the next slide.
We're just trying to get everyone adjusted, I think, to doing the polls. We have 24 people who voted so far, and it's starting to slow down. So I think we're just going to give it another 5 seconds. And we're going to end the poll now. And I'll just share the results.
Okay. So the answer was number 2, left cervical myelopathy. And let me just go back to the slides here. So you have a left Horner syndrome, which suggests that the lesion is somewhere on the left side of the nervous system, either on the left side of the brainstem or the left side of the cervical cord or the left carotid artery. And at the same time, you have a left-sided hemiparesis, which suggests that the patient has either a right-sided brain problem or brainstem problem or a left-sided spinal cord problem. And the best overlap, the best place which accounts for both findings is a left cervical myelopathy. This is taken from an article, a case report of Brown-Séquard syndrome associated with Horner syndrome. So it's a fantastic teaching case for trying to understand the pathophysiology. And neurology is sort of like working as an electrician. You're trying to figure out where the lesion is that explains all the different pathways and all the different pathologies. But most of the time, it's not that clear cut. You need more information to be able to get up to a good level of certainty about the diagnostic probability. And so it's not clear that we can simply multiply the individual likelihood ratios by each other. People have derived these clinical decision tools, which are based on combination of different findings from history and physical examination and tests. So what we see right here is the appendicitis inflammatory response score, which allows you to sort of grade things. But the problem with some of these scores, which we're just evaluating one condition, is that diagnostic probabilities are interrelated. So to try to explain this, let's say a patient comes in because of sudden onset abdominal pain. It's most likely that the patient has only one diagnosis. It'd be very unlikely that they have pancreatitis and mesenteric ischemia and a ruptured abdominal aortic aneurysm all occurring at the same time. So they have most likely only one diagnosis. So the sum of all the diagnostic probabilities for all the different possible diagnoses is 1. And if you're down to 2 different diagnoses, anything that increases the likelihood of one diagnosis will decrease the likelihood of another one. So for example, 50-year-old comes in with chest pain, and you do the sum of different probabilities, and then you ask the patient, well, is your chest pain worse with inspiration? The patient says, yes, it's definitely worse with inspiration. Well, then that has modified the probabilities of all your different diagnoses in a certain way. And Wells' score for pulmonary embolism incorporates that into the scoring system. That suddenly you get more points if you can't think of another diagnosis that's more or less likely. There's some weird quantum physics that correlates to this, and it's called entanglement. So the idea here is that you have a spin 0 particle that decays, and there are 2 spin 1/2 particles that travel opposite direction. And they're either a spin up or spin down. And because of the principle of conservation of angular momentum, one has to be a spin up and one has to be a spin down. But because of quantum mechanics, the odds are 50-50 that spin up or spin down for each particle. And the weird thing is, once you measure one particle and determine its spin, it automatically seems to determine what the spin of the other particle is instantaneously. And Einstein did not like that. He called it spooky action at a distance, and he was very much against quantum mechanics. But there have been studies, for example, between different islands in the Canary Islands that have shown that this seems to be how it works. So really interesting analogy, I think, between decision making and and quantum mechanics. But what we really would want at the bedside is a clinical decision tool that doesn't just tell us likelihood of appendicitis versus non-appendicitis. We'd like to have the relative probabilities of different diagnoses. And maybe the future will help us with this. I mean, there's some enthusiastic articles about machine learning that can improve diagnostic accuracy, and algorithms which will soon be available. I haven't seen them yet. And it could well be that in the future, we're going to be working with iPads and at the bedside, putting in information that we get from the patient and having supercomputers helping us in real time, giving us information about likelihood ratios and relative probabilities. But at a certain level, getting the data from the patient is highly complex. And here you have a patient on the left saying, I have chest pain, but at the same time, she's conveying that she's feeling quite well. And the doctor on the right is saying, oh, I'm not that worried. Or she's thinking that this is non-aortic dissection. So there's tons of information that we get from the way the patient's behaving in the room. And I don't think any computer is close to being able to do that for the next 100 years. So again, a weird analogy with quantum mechanics, where Carlo Rovelli argues that the only thing that really exists is interactions between particles and actually not particles in themselves. So he's coined this statement, reality is reduced to relation. So a lot of stuff going on when we're in the room with a patient. Okay, so getting back to diagnoses, this is how the Institute of Medicine defined diagnostic errors. They defined it as to establish an accurate and timely explanation for the patient's healthcare problem, or a failure to communicate this explanation. And I have to say, I don't like this definition. First of all, I don't think that failure to communicate is a diagnostic error. I think it's just bad bedside manner. And then I don't think that we in emergency medicine can be expected to provide an accurate and timely explanation for the patient's healthcare problem. We focus on time-sensitive conditions. So we're mostly interested in these diagnoses where treatment within minutes to days decreases morbidity and mortality. For example, PE, stroke, active GI bleed, sepsis. We're not really interested in making the diagnosis of multiple sclerosis. That's not our job, and that we don't have the resources and the time for that. The other thing I don't like about the Institute of Medicine definition is that I think there's two sides to the coin here about diagnostic errors. There might be something called a type 1 diagnostic error where we miss the diagnosis, we miss a PE. But then there's something else. There's a type 2 diagnostic error where we're ordering CT angiograms on everybody because we never want to miss a PE, and we're creating more harm than good by doing this. So I think we need to take into consideration this other type, this over-investigation aspect to diagnostic errors. And then finally, I think we in emergency medicine, we are very dependent on point of care information. So we should be very good at taking a good history, physical examination, using ultrasound, blood gases, and EKG. These are the types of information sources which are point of care, immediate information that we need to be very good at. So I would propose this as a definition for diagnostic errors in emergency medicine. That's failure to approximate the probability of time-sensitive conditions based on available point of care information. I know it's a bit of a mouthful, but I think that comes closer to what we're after. So what are the sources of diagnostic errors? Some of the sources are just system-related, limited time, interruptions, and no-fault errors, so uncooperative patients. But the cognitive sources of errors, those are the ones that we can actually work on and try to avoid. And here's a picture of Daniel Kahneman, who's written a book called Thinking Fast and Slow. And I'm certain that many of you have seen this book and read parts of it. So he argues that there are two systems that we use in our brains. there's system one, which is unconscious. It focuses on pattern recognition, coherence, jumps to conclusions. It's effortless. And I don't know if any of you are Star Trek fans, but think about Captain Kirk. He's almost always right, very intuitive, emotional. That's system one. So system one is what makes us see these two yellow lines as different in terms of length, because we're interpreting them within a context, and we're looking for coherence. And then system two is Spock. So conscious, analytical, rule-based, tedious. So here's one cognitive source of a diagnostic error. And what you see here is just too little information. It's difficult to recognize who this person is. Now, here we're all aware that there's too little information, but that's not exactly how system one works. What system one works is that it jumps to conclusions, and it can jump to a very convincing conclusion based on very little information. In this COVID era, I found that sometimes I meet these patients and I can only see what you see on the screen. The rest is covered by a mask. And then I ask them to take their mask off so I can, determine whether they have facial palsy, or for example. And then I'm surprised by what they look like underneath the mask. And I think that's system one at play. My brain has generated sort of like an image of what they look like. And it's bizarre that I'm surprised by what they actually do look like, because I didn't have that information to start off with. But here's an example of system one at work. I mean, we see this white triangle, even though it doesn't really exist, and it's based on very little information. Here's a second cognitive source of diagnostic error. How many of you recognize who this person is? And Emil, I'll need your help with this one to move on.
Sorry, Eric. Could you repeat that?
Yeah, just wondering how many of the audience here recognize who this person is?
So if we just get people to write either in the chat or in the Q&A. So we have a suggestion of Marie Curie.
Yeah, close.
Yeah, close. We actually have two suggestions of that.
Okay, very good. So this is Lise Meitner, and she should have been awarded the Nobel Prize for nuclear fission, but she was a woman and she was a Jew, so she didn't get it. But here the problem is, it's not a lack of information, it's a lack of knowledge. So, and sometimes we're quite aware when we see a face that we don't recognize who this person is. But the problem again with system one is that we see what we know, as Goethe said, and we might have a zebra in front of us, but we don't know what zebras look like. And so what we see is a horse. We're blind to the stripes. And then here on the right, here's your third source of diagnostic errors. And on the right-hand side of the screen, you can see an image which can be interpreted as an old woman or as a young woman. The issue here is not lack of data or lack of knowledge. It's the fact that it can be interpreted in different ways. So a patient might present with fever, dyspnea, chest pain, elevated white count, CRP, and an infiltrate in the lung. And your brain might say to you, this is a pneumonia. And yes, it can fit with a pneumonia, but it can also fit with a pulmonary embolism. And that could be another source of a diagnostic error, a phenomenon called premature closure, where we too rapidly jump on the first diagnosis that we think is plausible. So faulty data acquisition, faulty knowledge, faulty interpretation, which is the most prevalent? And it's very unclear. Here's a study which showed that there's a correlation between performing a good neurological exam and suspecting stroke. And if you look at the data, it suggests there is this correlation. But one interpretation could be, well, if we only did good neurological examinations on everybody and got the data, we wouldn't miss that many strokes. But another one could be that based on the patient's presentation, you never suspected a stroke in the first place because of faulty knowledge. And that's why you didn't do a good neurological exam. So I think we're often taught how the typical appendicitis presents. We're taught that in the textbook, but we're not really taught about how much it can vary from the standard presentation. And that's what we need to get good at. So the chameleon picture on the bottom right here, it illustrates the fact that certain conditions can present in kind of weird ways. So Jeff Norman wrote that the root cause of diagnostic error is difficult to study because errors tend to be defined in hindsight. And we don't really know what's going on in the mental processes up there. Here's the next poll here. So here's a 20-year-old guy, presents with chest pain. What do you think this is? And Amy, I'll leave it up to you to give me the go-ahead for one.
We're getting to 40 votes, but they're coming in quite quickly right now. So I think we'll just leave it another 10 seconds and then we'll continue. Just give the last an opportunity to vote. 4 seconds more. All right, so it's slowed down now. So I'm just going to share the results. And atrial fibrillation with left bundle branch block is the most popular option.
So the answer here was the first one, AFib with accessory bypass tract, and it's the key to distinguishing that and the left atrial fibrillation with the left bundle is these small little spikes that show up sort of in the middle of everything. These argue against that the patient has a bundle branch block if suddenly you get a small spike, a small QRS complex. This argues more for, or it's pathognomonic for the fact that you have impulses coming down your bypass tract and your His-Purkinje system. And then from time to time, the bypass tract is silent and you get something that looks like a capture beat, a small QRS complex. So, and if you treat it wrong and you treat it as an AFib with AV nodal blockers, you'll get an acceleration of the rhythm and it can degenerate into VF. So here the problem is actually it's lack of knowledge, and that's okay. I mean, we can't know everything about everything, but the data, all the data was there in the EKG. It's about knowing what to look for. This is what the EKG looked like after the guy had spontaneously converted back into a sinus rhythm. He has a beautiful delta wave down here. So zebras, when we talk about zebras, we're focusing on the false positive aspect of the diagnostic error. And when we talk about chameleons, we're focusing on the false negative. But there's this mixed identity going on in each of these diagnostic errors. I'll just quickly illustrate one case. So I'm at the end of my shift and I'm trying to tidy things up so that I can go pick up my children at daycare. And this nurse comes up to me and says, "Can you sign this EKG from this 92-year-old woman?" And I thought this was a pretty scary looking EKG. I mean, it looks like a STEMI in V2 to V4, and there's even ST elevation in the inferior leads. So I ask, "Where's the patient?" And I rush in to meet the patient. There's this 92-year-old woman who's sitting upright in bed, and I say to her, "Do you have any chest pain?" And she can't really answer, but she shakes her head back and forth. And this woman has been sent to the ED because of suspected stroke. So she'd previously had a stroke, and so she had a certain degree of dysphagia. And then that morning, she couldn't talk anymore. So the personnel at this nursing home thought that she had had a new stroke, and that's why they sent her to the ED. So I said to her, "Well, are you sure you don't have any chest pain discomfort?" "No," she doesn't know. She shook her head. So then I asked her, "Are you a little boy?" And she looked at me as though I was crazy, shook her head. "Are you an old woman?" "Yes," she nods. "Okay, do you have any chest pain?" "No." So I couldn't figure out what was going on. And I go back and look at previous EKGs, and the ST elevation is definitely new. And then the nurse comes up and says, "Here's her blood gas." And there's her lactate of 6.2. So what she had was a urinary tract infection. That was her main diagnosis. Infection in the elderly. It's a chameleon. And because of that, she got some ischemia to her head and an ischemia to her heart. But the STEMI and the stroke, those were zebras. Those were sort of like false positive diagnoses, and the false negative one was the UTI. Just to illustrate how complex diagnostic reasoning can be. We'll jump over the push-up pause because we don't have much time, but I'm just going to race through a couple of the last slides here before we take the question and answer period. How do we know which of these three sources of cognitive diagnostic errors is most important? I don't know. What I need when I'm working in the ED is something that's robust. There are some suggestions that we can apply cognitive debiasing strategies and be aware of our biases, and I don't really think that works. There are too many different biases out there, and there are a bunch of studies that show that these cognitive debiasing strategies, they don't really work. This is what it feels like for me when I do my shifts. I'm running around all over the place and answering the phone and multitasking and trying to keep everything in my head. So I need something that's very robust. And this is the strategy that I advocate. It's a 0-1-2 strategy where Mr. Bean symbolizes just getting the data. So it starts off as this. Why is the patient here? What's their chief complaint? Okay, chest pain. So you need to try to get this part right, and then you can apply a checklist. So here we have a checklist for chest thoracic pain, which is localized to or under the chest wall, including the back, but not exactly in the midline. So if that's what the patient is presenting for, then the next step is get your data. Here's a mnemonic for this background pretest information, MAPLES. I usually ask this question, go through the MAPLES very early on. I say, okay, I can see that you're here because of chest pain. That's great. Before we talk about that, I have a couple quick background questions. What medications do you take? Are you allergic to medication? Just go through this. If the patient's really sick, I just go through MAP. And then you get information that, according to the literature, will help you tweak the diagnoses up and down. So information from the history, the physical, troponin if they're over 40, and EKG. Okay, I think you can justify this based on the literature that this is good point of care information to acquire. When you're doing this, the little Kirk in your head will be screaming different diagnoses, and that happens unconsciously, and that's great. What you need to do is have a little bit of Spock in you at the last moment and consciously consider time-sensitive conditions that we can miss sometimes. So for all patients with chest pain, consciously consider, could this be an acute coronary syndrome, a PE aortic dissection? And if you feel like you can justify why you don't think that it is, well, then you're fine. I like this issue of this concept of standard operating procedure. So the idea is to have a robust definition or description of the different processes that we do and how we do them, so that we can reliably reproduce the process with high quality every time we do it. And I see checklists as a knowledge translation tool between the standard operating procedure and what we do on the shop floor. So how checklists work is that they direct your attention towards certain facts, and they also can provide certain facts that are hard to keep in memory. I don't see checklists as a straitjacket. I think they're more like a walking stick, a cognitive aid. And checklists have a good track record in the flight industry. I think it's nice to hear, flight attendants, disarm slides, cross-check, report. There people are following the procedure, and good that checklists are being applied in surgery. So I think we should be using more checklists in emergency medicine, or they should be available and easily available, and we should constantly be tweaking them. One way to get better at diagnoses is to read up on the patients that you have treated and admitted. I think we need feedback to constantly adjust and tweak what we're doing. So I think it's paramount to follow up on the patients that you have admitted. In Sweden, there's been some controversy about whether we're allowed to do that because we're no longer involved in the patient care. But I think it's our responsibility to do so. so that we can get better at what we do. I also think we need regular classroom training. We need to be able to meet, discuss weird cases, bring up the chameleons, bring up the zebras, bring up the atypical presentations. And the best place to do that is together as a group, learn from each other, and have this regularly recurring. It's very difficult to do this on the shop floor when there's patients that are waiting. I also think that we should talk to each other more when we work. So flight pilots, they work in pairs, police, they work in pairs. There's some cross-checking going on. And this is a very interesting study by Freund, who looked at the effect of systematic physician cross-checking on adverse events. So physicians were just asked 3 times during their shift to meet with each other and just to discuss some of the patients, the more complicated patients that they were thinking about. Just by verbalizing, they were able to reduce the rate of adverse events by 40%. And what's the mechanism? I don't know. Could be that I know that I'm going to meet with Emil and discuss a patient, and so I'm more careful about getting data. Or it could be that once I start verbalizing, I listen to myself to forcing Spock or system 2 to kick in. And then I realize that, yeah, of course this could be sepsis. I need to admit this patient. This is a study that looked at parole officers who are supposed to be very objective, and parole officers start off the day and they make a proportion of favorable decisions that you can see on the y-axis. But then gradually, as they get more tired, the proportion of favorable decisions go down. And then suddenly with the dog, that's a lunch break. And then suddenly it goes up again and it goes down again. And then they get another food break and it goes again. So I think what happens here is that when you're tired and hungry, kicking in Spock, system 2 thinking becomes more and more difficult and more tedious. And we err on the side of least resistance. So for these parole officers, it's to deny parole. For us, it could be that the path of least resistance is simply to send the patient home, and that's dangerous. So I think we need to be aware of that. So here are my final summary slides for this part here. We in emergency medicine, when it comes to diagnosis, we're interested mainly in these time-sensitive diagnoses represented by the clock. Obviously, we care about every diagnoses, but those are the ones that we're mainly interested in. Bayes' theorem provides us framework for assessing the probability of these diagnoses. Diagnostic errors are the result of faulty data acquisition, faulty interpretation, faulty knowledge. My hunch is that faulty knowledge is a bit of a problem. I think we need to be humble about this and keep on reading. I think checklists is a way to mitigate the risk of faulty data acquisition, to try to go through the checklist at the beginning, make sure you get the necessary point of care data. And it's also a way of mitigating the risk of premature closure. Force yourself to think, here are the 3 key diagnoses I don't want to miss. Can I evaluate them? Can I roll them out clinically? I think we need to follow up on our patients to get better at that. We need protected teaching time where we can talk to each other about diagnostic reasoning, bring up good cases. On the shop floor, when we're tired at the end of their shift, go up to a colleague and say, hey, can I just quickly review a case with you so make sure that I'm thinking right? And I think we need to eat during our shifts, and be aware that we're dangerous when we're hungry and tired. Thank you.
Brilliant. Thank you so much, Eric. I'm just going to stop your sharing because then I think we'll be able to get both of us on. There we are. So we have another 35 minutes left. So I'm sorry, how much time were you planning on your second presentation?
10 minutes about.
10 minutes. All right. So we have some time still for Q&A for this session.
Yeah.
Yeah, brilliant. Because then I just want to invite people to write their any questions they have for this presentation in the Q&A. And we actually already have quite a few. So if it's all right with you, I'm just going to jump into them. And then please, everyone, just feel invited to write any questions you have, as this is the opportunity of a lifetime to ask these questions to the probably the greatest expert we have in Scandinavia on these areas. So we have one question from Peter Thomas Thompson, who I know is a personal friend of yours. And he asks, how do we know when to even think ACS or PE in an undifferentiated population? And how much information needs to be gathered to say that the assessment is sufficient? So, and he sort of summarizes that, how do we learn to see what we need to look after and listen to what we need to listen for?
So I'd like to start off by saying that I'm on the process with all of you out there trying to get better at diagnostic reasoning and better at decision making. I don't consider myself an expert, and I'm always humbled when I talk with Peter about these issues. So I don't have a great answer out there. I think what we need to reflect. We need to have a good way of picking up on missed diagnoses. That's the start, and I'm not sure we have a good system for that. So we need to have a way of deciding how many myocardial infarctions, how many ACSs are we missing, and then when we find those out, then we need to go back in retrospect and say, how do they present? If they presented with just undifferentiated fall, well, is the solution to do EKGs and troponins on all of these? And then we need to sort of test this out. It could well be that if we do that, we're going to increase the amount of work in the ED, decrease productivity, pick up a lot of noise in the system, and then we're not actually going to benefit the whole patient population. So I don't have a great answer, but I do think that the starting point is trying to track what we're missing, and then to not jump to radical. Let's do a CT everybody over 60 who comes in with abdominal pain because someone missed a ruptured aortic aneurysm. I don't think it's that simple.
I think that's exactly the gist of this, why this talk is important, isn't it? Because, I mean, we do have that tendency to say that once we've had a catastrophic case that might have been just an uncatchable case, we tend to maybe end up making decisions that over-diagnose patients and actually end up causing more harm than that rare one catastrophic case. So my question is, this catching up on what we are missing, what's your suggestion to that? Are you thinking morbidity mortality conferences, audits? How do we sort of ensure that we get that data?
Yeah. Again, I don't have a good answer to that. I think my impression of our ways of picking up on diagnostic mistakes and poor management is that it's very erratic. It has to do, it's some of the ones that we discuss, I don't think there was a diagnostic error. I'm aware of other ones where I do think that the physician messed up, which are not brought to the spotlight. So I think it's, I don't have an answer to this, but I do think that this is a serious problem in healthcare, that we're not getting the feedback that we actually need. I do think that there's an aspect of personal responsibility for all of us to constantly reflect on what we're doing. And for the patients that we discharge, often there's not much available follow-up to look at, but the patients that I admit, I do think that it's good to see what's happened to them during the coming days and to see whether I thought right, whether I admitted to the right level of care, or what my brilliant colleagues downstream have done and thought about.
So the self-reflection on your personal cases.
For the time being, but the ideal would be to have a better system.
Yeah, I think that would be ideal. All right, thank you very much for that. And then we have Charlotte Brun-Mølvang asking, how do you explain ST elevations in relation to infection? In that situation, one would probably expect type 2 infarction and ST depressions. Could it be cerebral triggered ECG changes?
Yes, another great question. So I'll start off with the last part. There are case reports of patients getting, for example, a severe intracranial bleed, and getting ST elevations just because of the noradrenaline surge. At least that's the hypothesis. And yes, I agree that that non-STEMIs having ST elevation is unlikely. I think in this case was a little bit extreme, but the point that I wanted to make was that there can be a blend of all kinds of different things going on at the same time. And in this case, the troponin was elevated, but we chose not to send her to the cardiologist and do a coronary angiogram. So, and that also comes back to what we're going to talk about now with decision making, where we're trying to maximize patient well-being. We decided that given that the patient was chest pain free, that it wasn't really in her interest to go through a coronary angio. So I hear what you're saying in your question, and I agree.
Brilliant. Thank you very much for that. Then we have Gerhard Tiewald asking just you personally, how do you supervise the most junior doctor? Do you have to examine the patient yourself, or are you in the room with?
Yep. So first of all, hi Gerhard. It's good to communicate with you, and I find that this is a difficult one. So what I try to do is bring up the checklist with the junior doctors I'm supervising, so that we're going through the checklist together. They know ahead of time what I'm expecting them to acquire from the bedside, and then I feel like I'm getting the data that I need to make a decision. And then what I do a lot with them is we do ultrasound together. So let's go see the patient, wheel in the ultrasound. I'm doing all, I try to do as much ultrasound as I can with dyspnea, abdominal pain. And then when we get there, I show I use my hand to represent the pointer, the probe, and my thumb to represent the pointer. And I put the hand on the patient and I say, okay, put the probe there. And I get them to start doing ultrasound right away. We look at the different structures, and at the same time, I'm getting a sense of who the patient is and what the patient is. So that's the ideal. It's not uncommon that I don't have the time to see the patient at all. And here I try to base it on my level of confidence in the junior resident. I work with great residents that I worked with previously, and there are a lot of them that I trust 100%. So I don't need to see the patient. I trust the information I get from them.
Brilliant. Thank you so much. I think we might move on to the next presentation then, because we've answered most of the questions. Is that all right with you, Eric?
Yeah, I think that's great.
All right, brilliant. So just share your slide again.
Yeah. Good. Does everybody see this decision making in the ED slide?
No, I think we don't have it yet. You need to reshare it.
Okay, let me try that again.
Yeah, we have it now. Brilliant.
Here, does that look good? All right, so this is our starting point again for this part. So you have this patient and you've acquired history and done a physical examination, and you have some EKG and ultrasound. And so now you have a relative probability for different diagnoses. And so now what do you do? So at least in Sweden, we can do all kinds of things. We can order all kinds of tests, send the patient home. It's actually really quite nice. Like in the UK, it's a lot more rigid as to limit what patients can do in the ED. But with this comes also responsibility, something called resource stewardship that's talked about in literature. So we need to try to be good at what we do. And Pat Kruskary, he wrote, good decision-making is the ultimate arbiter of a well-calibrated clinical performance. So what's the goal here of decision-making? This is a classic textbook about medical decision-making by Soxblatt, Higgins, and Martin. And what they argue is that the goal of clinical decision-making is maximizing the patient's well-being. I think that we can be a little broader than that. It's maximizing well-being, and it doesn't just limit itself to the patient. So getting back to Jerome Cassier's quote, after talking about the fact that diagnostic certainty is unachievable, he writes that our task is to reduce the level of diagnostic uncertainty enough to make optimal therapeutic decisions. I mean, it's a brilliant quote that summarizes things. So in decision-making, we talk about these decision thresholds, such as the test threshold and the treat threshold, which are dependent on the patient's, the diagnostic probability. So if the probability of the diagnosis is above the treat threshold, that means that the patient will benefit from treatment, from being treated regardless of the test result. An example would be suspected pneumonia, where you might or might not order a chest x-ray, and the chest x-ray might or might not suggest pneumonia. But if you think it's pneumonia, and you think about what's the cost of being wrong, it's definitely in the patient's interest to start antibiotics. And then you have a test threshold. So if the probability is below the test threshold, then treatment does not benefit the patient regardless of the test result. An example here would be someone plays soccer, football, gets hit in the calf, comes in with calf swelling. Should we take a D-dimer? No. I mean, the pretest probability of a PE is, a DVT is 0 here. And even if the D-dimer is elevated, it's still going to be 0. It's not going to, you're not going to treat this. So if the probability is between these different thresholds, then the patient then the test should be done, because then the patient will benefit if the treat is positive, and you won't treat if the test is negative. For example, this example here. So there are other decision thresholds. So for example, admit, discharge, those are different thresholds. Sometimes I meet a patient that's elderly, doesn't function at home, comes in, and you can determine fairly quickly that they've crossed the admit threshold. And that actually helps with further management, because you don't need to be as thorough and plan for all these eventualities if you're admitting the patient, and some of your brilliant colleagues are going to be taking over the care of the patient downstream within a short number of hours. So here are the factors that determine these thresholds. In theory, it's nice with these test and treat thresholds, but the problem is that there are many different factors that weigh into where these thresholds actually lie. So there are the risks and benefits of different investigations. There are the risks and benefits of different treatments and how soon we should treat. And then there are all these other things. So there's the patient's wishes, and there are the resources that are available. Anybody who tells me that my decision should not be influenced by the number of beds available in the hospital hasn't really worked in the ED. I mean, if there are no beds, then that means the patient needs to stay in the ED for many, many hours. And that's not great for the patients, and that's not great for the staff, and it's not great for other patients that are around. And so you then sort of are forced to make different decisions and tweak the system. And then I think we should also take into consideration what the relatives want. So here's a very positive article again about big data and machine learning. And machine learning will dramatically improve our ability to establish prognosis, and better prognosis will help us make better decisions. And they predict that prognostic algorithms will come into use in the next 5 years. I haven't seen them, I can say, and I'm a little bit skeptical to this. Elliot Eisner said, not everything that matters can be measured, and not everything that is measured matters. So here's a case about this. Here's an 87-year-old woman who presents because of sudden onset of central chest pain. Background, she has Alzheimer's, otherwise she's quite healthy. Her vital signs, if you look at them, increased respirate, saturation is a little bit low, Heart rate's a little bit high, blood pressure is maybe a little bit low, she has fever. You take out your checklist. Where's the chest pain? You can barely get information from her. She's distressed and she has Alzheimer's. So the checklist doesn't really help you very much for your history. You do your best job with a physical exam. She's short of breath. She has some mild rhonchi. You whip out your ultrasound. You don't see much in terms of fluid or anything. You have a blood gas, doesn't really tell you too much. Mildly elevated lactate. Then you have an EKG, and you can see on the right how I would interpret it. I'll just cut to the chase for the sake of time. Maybe some mild ST elevation in V1, V2. And then there's some ST depression in the in AVLN1 and V5, V6. So now I think we've come to the pole here.
So the question is, what would you do, right?
Yes, that's right. How would you treat this patient? You're in the resus room with her, and what would you do with her at this point? So she has advanced Alzheimer's, but otherwise she's healthy, and she's coming with, and this is the data that you have. So Amy, let me know when I can move on.
Yeah, we're just going to give it another 7 seconds, and then because this is a tough one. So our 29 people have, and we're going to end it. I'm just going to share the results. It's pretty spread out.
Yeah. So I think decision-making is difficult, and I don't think there are clear-cut answers to these questions. I can tell you what I did with her. So I sort of assumed that, well, this could be an acute coronary syndrome. I didn't think aortic dissection was that likely, but sudden onset of chest pain, you can't get much data from her. Could this be a PE? Could this be a pneumonia? So if you just focus on the aortic dissection and you think to yourself, should I do a CT aorta? And that's your decision. I think what we need to do is we need to be like chess players, not just think one move at a time, but several moves at a time. So could this be an aortic dissection? If I don't do a CT and she doesn't have an aortic dissection, then everybody's happy. But if I don't do a CT and she has an aortic dissection, then she dies. If I do a CT and there's no dissection, well, people are happy. If there is a dissection, then you talk to the thoracic surgeon, who will probably say, no way. But if they, and in that case, she dies. Otherwise, I'll take her to the OR. Then she might not survive the OR. I mean, it's a big operation, then she dies. And if she does survive, then she's admitted and trying to recover during at least a couple of weeks. And during that time, she might die because of a pneumonia or PE, or she might survive. So, I mean, these are the kind of things that we try to factor in. And I decided that going down the aortic dissection route just didn't make any sense. And so I sort of removed that from the equation. And it's a little bit like this. If you feel that there's no threshold where treatment is actually going to be indicated, well, then there's no, in theory, no threshold where it makes sense to do the test. So what I did with her is I gave her aspirin and low molecular weight heparin, and I gave her some morphine. And then I figured, well, she needs to be admitted, but there were no beds. So she was lingering in the ED for several hours, and I looked at her blood tests, which show elevated troponin and white count. And so I ordered a VQ scan because she had renal failure, and it showed a 50% PE. And I thought to myself, this is good. I can discontinue the aspirin, and today she would be put on a NOAC. At that time, she continued with her low molecular weight heparin, and sort of the diagnosis was achieved, and it was easier to actually manage her. But here's another example: 90-year-old woman with head trauma, advanced dementia, repeated falls. So she's fallen in her nursing home and she's sent to the ED because of this head trauma. And the son shows up. This was before COVID. And according to the son, she's in her usual demented state. And I said to the son, if we do a CT of her head and there's no bleed, then she goes back to her nursing home. If we do a CT of her head and there's a bleed, then I'll talk to the neurosurgeons and they will not operate on her. And then she'll go back to the nursing home. So I'm really skeptical about the value of doing a CT of her head. And the son said to me, I understand what you're saying and I understand the logic, but I would still like to know whether she has a bleed in her head or not. And I said, that's fine with me. And so I ordered a CT of the head. And I think that's justifiable. Here, we're not doing the CT to maximize the patient's well-being, but we're taking the relative's well-being into consideration. Here's another poll here. 71-year-old woman with abdominal pain. So she has advanced dementia. According to the personnel, she's having these bouts of abdominal pain and she tries to bite anybody who comes near her. So when I started my shift, had very little information. She's walking around, causing trouble in the ED, her abdomen's soft. We were able to get a capillary CRP on her. So how would you manage this case?
We're just going to give it another 5 seconds. I think people are starting to catch on, Eric. At least there's more unanimity. Let me just share the results.
We'll see. Yeah. Awesome. Interesting. So this is what happened with her. I decided to sedate her and do a CT. My reasoning was I trust the personnel who are telling me that she has pain. They're the ones who really give me the information that's needed. I do think that even though I can't communicate with the patient, if she's having pain, we in healthcare need to do something about that. So we sedated her, and we can have all kinds of discussions about the legal aspects of this, but we sedated her and did a CT, and it showed this weird clump low down in her sigmoid, and we didn't really know what this was. No one knew. So the surgeon said, well, give her a lot of laxatives and send her home. So I said to the personnel, I'm not sure this is going to work, but our plan is laxatives, home. And then I said to them, in 1 week, I'm going to be on this shift here. So come back if she's continuing to have pain. And then 1 week later, I was hoping that she wouldn't show up, and there she is. She showed up again with her personnel. So we sedated her again and did a bedside x-ray, which showed this weird clump here that you can see here. And so then I talked again to the surgeon, and we arranged to do endoscopy, and they had to go up with a gastroscope. And what they were able to find was that this was 22 kronor. So it was like 5 crown coins that she had swallowed. They were layered upon each other with 2 1-crown coins above that. And there was some sort of like stenosis in her sigmoidium. So they were able to pull that through. And I asked them afterwards, they called me because they knew I was interested. And I said to them, what did you do with the coins? Did you buy her an ice cream? And they said, no, the coins were really, really äckliga, disgusting. So they ended up in the trophy scope, the trophy place with all the foreign bodies that they've removed from people. But that felt good. I must say that we were able to do some solution that felt okay for her. And I find decision-making is difficult. Every shift, I have to sit down and think, like, what should we do here? So we need to learn how to tolerate uncertainty. Here's an article that talks about the next medical revolution, making imperfect decisions based on imperfect data, limited knowledge, diagnostic uncertainty, coupled with the uncertainty that arises from unpredictable patient responses to treatment and from healthcare outcomes that are far from binary. I think that really sums it up quite nicely. What's interesting is that this is nothing new. William Osler talked about uncertainty in medicine. What I think is new is that we have a lot more information available, even though we still have all this uncertainty. We have a patient population that is less risk tolerant. When I grew up, we went skiing without helmets on. Now everybody wears helmets. And people are not very risk tolerant anymore. So what can we do about this? I think we need to have good shared decision-making between the patient and the physician. I think we need to have good dialogue. This is something that Peter Tagmusa-Thompson talks a lot about, the importance of communication, the tremendous value of communication between physicians and patients. And we are the experts. We know a lot more than the patients do about the relative benefits and risks of different investigations and treatments. So I don't think this is about saying to them, here are the options, you choose. I think what we need to do is we need to think, if this patient were my relative, what would I suggest? And then we need to communicate this to the patient and then involve them in the decision-making and justify and explain what we base our decisions on. I'd like to finish up with just marketing the Emergency Medicine Core Competencies course. So this course is a 3-day course, focuses on a lot of scenarios. So it's easy on the lectures. It's full with interesting cases. The idea behind the course is that it's the bridge. It's a bridge towards local recurrent scenario training. I think that's the key. The key is not sending your residents to courses. The idea is you take the course, then you can become an instructor. You can teach the course. Once you've taught the course, you can run the course locally. And when you do that, you acquire all the information, all the data from the course, the scenarios, and you get access to all the scenarios that I've developed within the scope of our regional clinical training here in Skåne. And feel free then to use them. I think we need to have regularly recurring local training sessions, which we can then adapt to our local circumstances. The other thing I think is key is in situ procedure training. It doesn't make sense to go to your training lab, practice cricothyrotomy with some set of equipment, and then realize that you have different equipment in your emergency department. So this is difficult to do logistically, but try to incorporate regular, very small, short training sessions where you practice different procedures and you get familiar with where your equipment is and how it works. If you go to lusem.info, you can find material there. Feel free to just download it and use it, adapt it to your local circumstances. These are the different procedures that we regularly train. And it's also good for residents to go up and say, okay, I want to practice putting in a chest tube. So they can go up after hours and practice with the models that are there. And finally, I think we can learn a lot from each other about how to implement new processes. So let's say someone says, okay, we want to implement emergency physician delivered procedural sedation in the ED. There's quite a lot of steps to take into consideration, not least the political aspects of this. And I think we can learn a lot from each other, from other places that have introduced it, and what are the tips and tricks about doing this? And is there always some material that can be, that we can share with each other? So we've done this within the scope of Sweden last year. And here's the date that you can pencil down. The idea is that people can listen virtually online. We try to get different clinics to talk about some of the things that they've introduced. We've all sort of like developed and implemented emergency medicine at different rates, prioritizing different things. So I believe that this is a good forum to accelerate and improve process implementation, learning from each other and sharing tips and tricks and material. Thank you.
Brilliant. Thank you so much, Eric. So we have just 5 minutes for Q&A for this presentation, which I think was brilliant, and I think it adds a very important aspect to your first presentation, which is exactly the thing. Like, when should we end our decision making? When does it no longer make sense? Is that our prioritization, or is it actually on the patient's based on the patient's needs and well-being, like your first case, which I think was very illustrative. So I just wanted to ask, because I think we might also have individually different priorities that make us continue investigating. So for you, it was, which I think is completely fair enough, the pain that this elderly lady was experiencing with the abdominal pain that actually meant that you ended up resolving this pain for this patient. For me, I often find that it's actually my own insecurities about my differentials that I feel like if we exclude this differential, that means that I'm more certain about the others, where I might need to actually do something that could help the patient. For instance, PE versus pneumonia, aortic dissection versus pneumonia, or something like this, where you could either give antibiotics, even to a patient you're not going to do surgery on. I think I don't know if that's necessarily fair, but what's your opinion on excluding something that you know that you're not going to treat on, simply to know that that was the cause of the patient's symptoms?
Yeah, I think that is fair. I mean, I think these diagnostic probabilities are interrelated. So if you're excluding a diagnosis, you're increasing the likelihoods of the ones that remain, and that might affect your test and treat threshold. Just to get back to one of the things you said about insecurity, I mean, I feel insecure every day when I'm working in the ED about decisions. So I do think that sometimes you wonder, do I have too much testosterone today? Am I being just way too aggressive and sending everybody home? Or am I being too finicky and over investigating? So I think here I like to talk to my colleagues as much as I can and sort of try to calibrate what I'm doing based on how they reflect. And I get comfort in finding out that they would do the same thing. And then when they do something different, I think that's really interesting, and it gives me something to reflect upon. So I don't have a good answer other than that these are essential aspects of what we do. And I think we really need to continue to collectively reflect upon and discuss this to get better at it. We can't get better at it if we just live in a little silo and just make our own decisions and don't listen to anybody else and don't get feedback from what happens to the patients.
Brilliant. Thank you very much. So there are actually quite a few questions left, but we're running out of time. So I could ask, I'm going to do one more question. And if you would be okay with that, if you could stay on afterwards and just answer in writing in the Q&A section, that would be brilliant. Just opening the Q&A section at the bottom of your screen, I think you should be able to see all the questions. So the one question I wanted to mention, I think is quite interesting, from Rasmus Holgaard, and was actually to the previous presentation. What are your thoughts on the 30-second eyeballing by the flowmaster / senior emergency physician as a pretest for a good outcome of a patient?
Yeah, that's a great question. I don't really have a good answer to that one. We're trying to do quite a lot of eyeballing right now in our ED because we've introduced 2 different flows because of COVID. And so we're trying to eyeball patients and decide as quickly as we can whether we need to do an antigen test or whether we need to do a PCR test to rule out COVID. And I'm worried about the eyeballing. I do think that lack of information is a problem and a cause of diagnostic error. So my gut feeling is that we need to be very careful about this sort of, patient looks fine, go home.
Yeah. All right. Well, thank you so much. Just afterwards in the break, let me know if you have any problems with the Q&A. We're going to go to the break, but before